up and this. Okay, can you? Thanks.
This is a nervous system. It is a network of many nerve cells that together work. They carry messages fast as lightning through your whole body. Don't even feel it. Every single thought and every action, every reflex and reaction is caused by interaction that results from the nervous system. Oh, yeah. The nervous system, the nervous system, the nervous system, the nervous system. Your brain, your spinal cord, and your nerves are connected together, and together they work. It's very complex. More than any object, a stimulus. It's when you feel something high. It's sensory receptors and they feel it alive. The signal goes through the sensory neurons now to what the spinal cord without a sound. It's signals in the spinal cord. The motor neuron, the muscle, it travels toward. Now you pull back real fast, ooh, because you didn't expect. Ladies and gentlemen, that was a reflex. Ooh, many nerve cells that together work. They carry messages fast as lightning through your whole body. Don't even feel a thing. Every single thought and every action, every reflex and reaction is caused by interaction that results from the nervous system. It's the nerve, the nervous system, the nervous system, the nervous system, the nervous system. Ooh, yeah, yeah.
So, who could tell me? I'll bring you a candy bar next time we meet. It's Gertrude Hawk. It's really good. What's this? What is this representative of? It's a difficult question. You're at the axon. You're on the right track. What?
Electrons?
Movement of electrons. And the movement of electrons over the membrane of the axon causes... Who said it? Nobody? Reaction. Oh, no.
Action potential?
Action potential! Good, remind me. I'll get you a candy bar next time we meet. An action potential, because what action potentials, I think that is such, and after, these videos seem silly, but there's, a method behind my madness. After we go over these lectures, watch these videos again, because there are actually things that happen in this video that are important physiological processes. Okay, now some of the videos are just silly, like one or two I've uploaded just to keep you entertained a little bit. But that movement of charged particles across an axon, right? And an axon carries messages away from a cell body. It's called an action potential. What happens when we turn the lights on? We have a movement of electrons, okay? A movement of electrons across the membranes of nerves and across the membranes of muscle make those muscles and nerves work, okay? Make those muscles and nerves work. And that is what we're seeing there. I think this is such a good little video, right?
Makes muscles
And nerves work. And that's what this is representative of. And it happens in a millisecond. That's how they measure these action potentials. Okay? So, pretty amazing. Now, I think there's one more video. Whoops. Parts of the brain. Okay, so parts of the brain. So really pay attention. What I want you to get from this little video is the lobes of the brain. Let's just do those really quick. Towards the front is what? Frontal. At the base of the skull in the back is occipital. Near the temple, temporal. At the top, if you were to think about where you put your hat, is going to be parietal. If I had a little, cap that sat on the back of my hat that would cover just about where the parietal lobes are. And that's just a basic, there's other deeper lobes as well, okay? But just those superficial lobes, okay? So try to pay attention to that. Let's see here. And then have everything else memorized by the time it's done. Okay, I'm on it.
Yo everyone, this is Connie Southeast. About to drop the beats. There ain't gonna be no pain, just parts of the brain. Ready? Here we go. Everyone around the globe has 4 lobes. I'm so wise that I move clockwise. Frontal, parietal, occipital, and temporal. You see, your frontal makes all the decisions. Parietal is all the wrap from your sense of touch position. Occipital is the all-seeing lobe. And temporal hears everything. Gnarly, yeah? Frontal makes all the decisions. Parietal gets touch position. Occipital sees you. Temporal hears everything. Ever wondered how you speak? I'll spill that info. Your angular gyrus turns the word into code, the word into codes and broken commands. And finally, your motor cortex speaks. Now isn't that grand?
Parts of the brain,
Angular gyrus makes code.
parts of the brain,
Key
yeah.
the codes.
Parts of the brain,
Commands.
parts of the brain, yeah.
And your motor cortex speaks. Some parts of your brain are old fogies. Brainstem, medulla, reticular formation, thalamus, and cerebellum. Medulla controls your breathing and heart. Reticular formation arouses you. Thalamus switches all the switches. Cerebellum keeps you balanced. But don't forget the brainstem.
Parts of the brain,
Medulla controls your breathing and heart.
parts of the brain,
Reticular
yeah.
formation arouses you.
Parts of the brain,
Thalamus switches all the switches.
parts of the brain,
Cerebellum
yeah.
keeps you balanced. Brainstem.
Limbic system's donut.
It's a little weird here, sorry.
Every two is going to controls fear and anger.
Pituitary gland helps you.
Parts of the brain.
Amygdala's fear and anger. Hippocampus helps your memory. Hypothalamus controls emotion. Your cerebral cortex is the maestro of your brain, so intricate yet so awesome. Corpus callosum connects your 2 hemispheres, unless you want split brain. Motor cortex controls all your movements, and your sensory cortex finds all your outer senses. Those are the parts of the brain. Isn't that flippin' awesome? Cerebral cortex is the maestro. Corpus callosum connects your hemispheres. Motor cortex controls your movements. Sensory cortex finds your senses. Nothing but the truth. That is your brain. Like I told you, no pain. My name is Kanye Southeast, signing off.
Okay, that's ridiculous, but it covers almost every structure and the generalized function of every structure that's applicable clinically that you would ever need to know. So if you have any interest in the different functional areas of the brain, watch that 10 times and get them into your head. I mean, like the screaming part and stuff is a little silly, but it's really good. Unbelievably good. Lady Laura, thank you. Okay, so central nervous system. So I was just going to list off review stuff, and then I went in and reviewed for you. Okay, so I've kind of put together a little review for you. We're going to focus on central nervous system. We'll focus on peripheral and autonomic nervous system in different lectures. Okay, nervous system is huge. I mean, when I lecture in A&P, I think I do 4 weeks of it, 4 3-hour classes. I mean, it's huge. There's a ton of stuff and it controls everything. So I'm going to try to keep it to 2 classes for nervous system because I know that we've got to get into other systems. Okay, so central nervous system. So I have a list of things that we should review and I have pictures, so let's go through them. Okay, so here's the list that I'm going to be going over. Vertebral column. So obviously, if you're going to talk about nervous system, you got to talk about the bones that encase it. I uploaded my lecture, my A&P lecture on bones. Okay, not on bone tissue, on bones. I kind of buzzed through some of it because what I do for them is I give them a workbook and I have them do all the point and shoot stuff. Like I don't stand there and go femur and tibia and fibula and whatever. And if you guys want that, let me know. I'd be happy to shoot it to you. Just send me an email. And so, one easy way to remember, I'm sure we all know these vertebral levels, but if they get fuzzy for you, think about the times of day that you eat. You eat breakfast at 7 a.m., you eat at noon, and you eat dinner at 5 p.m. There are 7 cervical, there are 12 thoracic, there are 5 lumbar if you have any problems remembering that, okay? So 7, 12, and 5. The way that we term it clinically, somebody comes in, they have whiplash, we throw up a lateral x-ray, they have a C4 fracture. What does that mean? Cervical, 4th cervical vertebra, okay? So, and then we've got the different bones of the skull pretty much correlate with those lobes. Occipital bone, frontal bone, parietal bone, temporal bone, and then there's more, okay? But the major ones correlate with the lobes of the brain, or vice versa. Wonder which came first, but anyway, okay? And then we've got the sacrum and the coccyx. And obviously those are going to be the tailbone. There's 5 fused sacral bones. There are 4 fused coccygeal bones, okay? And what happens is the spinal cord, and we've got the brain, we've got the midbrain, which will dip down a little bit into C1 a little bit, okay? And then it'll turn into the spinal cord. In the spinal cord, so we're on vertebral column slide for my people at home. And then the spinal cord will come down in the kind of that middle area all the way down to what level? L1, L2, okay? That's why we could do epidurals at 3, 4, 4, 5, okay? Because at that point, the spinal cord ends as a little sort of cone-shaped structure. And then we have all these nerves that come down. It's my favorite anatomical structure. Okay, we have all these nerves come down. Let me bring my people at home a little bit closer. So cord comes down, and it's a rounded conus medullaris at L1, L2. You don't need to know that. L1, L2. And we have all these nerves come down that'll go to the pelvic base and the lower extremity. What is that structure called? Cauda equina. Because it looks like a what? Horse's tail, the bottom of a horse's tail. Okay, so cauda equina. This may be in the notes. I may be getting ahead of myself, right? Is this on the next slide? Okay, so let's move to the next slide, which is cauda equina. Okay, you can see there's a good picture there of that. Now, the reason that that's important, let me bring my people at home in, okay, is the cauda equina is a series of nerves which will go to the pelvic basin and to the lower extremity, yes? Okay. Now, look at what big bone they go right by. It goes by all the lower vertebral lumbar bones, and it also passes next to the sacrum. Okay, let me tell you a little story. I had a patient who was actually a friend, so she had my cell phone. She called me at like 9:30 at night on a Sunday. I'll never forget it. You have those moments in life you never forget. I was sitting up in my bedroom and I was watching TV, and she goes, "Hey, what's up?" I'm like, "Nothing, what's going on?" She goes, "I really hurt my back. I think you need to see me." And she's not one to be like that. And I was like, "All right, what's going on?" Well, she went sledding and landed on a rock on her sacrum. And she literally said to me, "My choo-choo-cha-chas are numb." Okay, so choo-choo-cha-chas obviously were her genitals. Now, what was my response? You need to go to the emergency room now, right? Because she had what syndrome? Cauda equina syndrome. She had fractured her sacrum and it had displaced back onto this grouping of spinal nerves, and she was losing feeling in her genital region. Okay, what's the next most dangerous sign and symptom of cauda equina? Loss of bowel and bladder. Very bad, okay, because this can actually lead to permanent neurological damage. Okay, so cauda equina, I just think it's really cool. Do you guys want to see cadavers? Do you guys want to take the trip to see cadavers or no? All right, you know what? Let's take a survey. Send me an email if people want to go, okay? Send me an email if you want to go. You know, if you don't want to, that's fine. You don't need to send me an email. I want to see how many people are interested. It's such a cool structure to see, you know, dissect it out. It's really neat. Okay, so cauda equina, that series of nerves that goes to the pelvic base and the lower extremity. Okay, so meninges. So we've got the brain. We went over the lobes of the brain. Now I want to go over one other thing before we move on to the meninges. So let me bring people at home out. Okay, so I want you to just stop writing notes for a minute and just envision something with me. Imagine that I, you know, hold a brain up to you. Okay, I want you to think of that brain like an orange. Okay, on the outside of the orange, we have that thin layer of skin, and then we have, you know, the pulp on the inside. Are you with me? The cerebellum, okay, or I'm sorry, the cerebral hemispheres are sort of like that orange. They've got this thin layer on the outside of gray matter. Are you with me? Okay. Now, gray matter versus white matter. Do you guys remember this from anatomy and physiology, gray and white matter of the brain? Let me tell you what it is, and then I'll tell you where it is, okay? We've got in the brain, obviously, nerves and supporting cells. And the parts of those nerves are going to be cell body, dendrites, and axons, okay? So I'm just going to do a multipolar nerve if you remember any of that. It's fine if you don't, okay? I want you to understand that we've got dendrites. I want to make sure I'm writing enough. Dendrites. The body is where the what is? The nucleus. Whoops. And then we've got the axon. And the general gist of nerves is that information will come in by the dendrites. It's processed in that cell body, and then it goes out by the axon. Are you with me? Okay. Now, in most, or a lot, I shouldn't say most, a lot of the nerves of the body, do you guys remember the myelin sheath? Okay. I know people are probably cringing and thinking, oh, I gotta go over this stuff again. But the myelin sheath is really important because what the myelin sheath is these series of deposition of little pockets of fat that help the transmission of nerve signals to move faster. Are you with me? Okay. So we've got the dendrites, we've got the cell body, which processes information, and then that information is sent down the axon. Okay. And if it has a lot of myelin on it, it'll move really fast. If it doesn't have myelin on it, it moves a lot slower. Okay. And there's a variability of speed because then there's lightly myelinated. Okay. But the myelin, that fat, makes it move quicker. Are you with me? Okay. So back to gray and white matter. Right? Back to gray and white matter. If we chop up a brain and we look at the inside, we're going to have gray matter and we're going to have white matter. I don't know why I'm putting it on the board. You guys know how to spell that. Okay. Okay. Now think with me for just a minute. Okay. Think with me for just a minute. Gray matter, guys, is going to be primarily dendrites, primarily cell bodies. Are you with me? Okay. So what's going to happen in gray matter? Information's going to be processed. So if I open up the brain and you see gray and white matter and I put my scalpel on the gray matter, what's going to happen in the gray matter? There's going to be some sort of processing of information. And this is where the brain gets so confusing because there's all these areas that do different processing. There's processing of visual, there's processing of motor. See what I'm saying? But let's just get the general gist. Okay, so gray matter is going to process information. Are you with me? Fat looks white. So those axons are going to make up the white matter, and moving through the white matter, we're going to be doing what? Sending information. Okay, all over to different places. Okay, are you with me? So I cut open the brain, and we see gray matter and white matter. And the way that the brain is anatomically structured is if I cut open one of those hemispheres, around the outside is going to be a layer of gray matter. That's called the cerebral cortex because it's around the outside of the cerebrum. And in that cerebral cortex, we're going to have all sorts of processing of voluntary information per se, okay? Sort of not those autonomic functions like heart rate, things like that. We're going to have vision. We're going to have hearing. We're going to have thought processes, okay? They're going to be in that cerebral cortex. Are you with me? Yes? Are you with me? Yeah? Okay. In that cerebral cortex, okay? Inside of that, you're going to have white matter. What does white matter do again? It's going to send it out or send it in, okay? So I decide that I want to put my arms like this. My cerebral cortex is going to tell my body to do that by sending information down to the cord and out the nerves, okay? I feel the pen in my left hand. So those sensory nerves are going to take information from that pen, from my hand, and send it up to my brain so I can do what? Realize that it's a pen. Are you with me? So there's information constantly coming in and out and being processed in that cerebral cortex and sent through this white matter, okay, down to the body and back up to the brain. Are you with me? Deeper on the inside of the brain, there's another collection of gray matter that's more, and I'm generalizing, more autonomic functions, hormonal functions, heart rate, thirst, hunger, okay? So we've got gray, white, gray, okay? The outside is, like I said, more, I hate to say voluntary, but more of those sense of like where you are in space and what you're doing, your emotional, not emotional, and your kind of motor reactions. And deeper in is more autonomic kind of functions. That's a gross generalization, okay? But that's a general gist. Are you with me? Gray and white matter, okay? So now let's talk about how they're protected. On the outside of the brain and the spinal cord, we have what are called meninges. Are we familiar with these? Do we remember these? There are 3 of them. There are 3 of them. Yes, no? Do we need to review them? We need to review them, right? Okay, so looking at this picture, so now we're looking at meninges of the brain and falx cerebri. Okay, there are 3 meninges. Okay, now I think once again that all these notes are on that first page. Okay, I made a list of like review stuff, and then I put a picture for each one of those if you're frantically writing notes. Okay, so meninges of the brain and falx cerebri. So did I put the 3 different names of the meninges on that first page? Okay, so dura mater, arachnoid mater, and pia mater, okay? So if we think dura mater, do you ever, well, I'm sure you did, get one of those darker, big garbage?
No, they're not on there.
They're not on there. Okay, that's what I sort of thought. So let me bring you guys back up here to the board. Okay, so this correlates with the meninges. There are 3 groupings of meninges. I can't believe I didn't put that up there. Okay. So we're moving from outside in. There's dura mater. Okay. Interestingly enough, mater means mother. Each one of these is a mother, which is kind of cool. Dura mater, arachnoid mater, and these are very important for us to understand, and pia mater. And they're not like far apart. I mean, they're boom, boom, boom. They're right next to each other, okay? You've got the dura maters, the very outside. Dura mater is actually termed the tough mother. That's what it translates into, dura mater, tough mother, okay? If you were to take one of those black garbage bags that you use to put like all your garbage in, that is almost the consistency of it when you dissect it out of a cadaver. I'm sure it's more pliable in a living human because it oxidizes and it loses some of its hydration. But it's tough. It's a tough mother. It's pretty, I mean, if I were to take a piece of it and go like this, it would not break. Okay, it's tough. Okay, so dura mater. Just inside of that, what's arachnoid sound like? Arachnoid sounds like arachnid, and it's actually a little spider-like It might mean you could barely, if I were to dissect it out on a sheep's brain for you and take a pin, the students always get mad in my A&P course because I pin it for them. They hate it. But you could barely see it. They're like, what is that? I can't see anything. That's how thin it is, okay? So arachnoid mater. And then if I were to take a brain itself and take the arachnoid off, Chia is a thin layer of cells right on the brain. It's a layer of, I believe, a simple cuboidal, which doesn't matter, but it's right on the brain. So if I were to show you pia mater, I would have to take the brain and take a pin and scratch it, take those cells off, and then I would have taken too much off, actually, okay? So dura mater, arachnoid mater, and pia mater. So that dura mater is pretty hard, and then the pia mater is on the brain, and then arachnoid sort of just floats a little bit, okay, in between them. Okay, are you with me? Okay. So now what happens, and I'm not going to get a ton into this, but the dura mater will actually fold in. You realize that there are two cerebral hemispheres, yes? Remember that? Okay. And also realize that my wonderful mentor that I listen to all the time talks about the consistency of the brain, okay? The consistency of the brain, he equates it to a stiff pudding. The brain is not. Like, I think we think of the brain as being really firm, and it's not. And if you let it outside of the skull without being preserved, it will just, just melt down. We have these invaginations of the dura mater called the falx cerebri, the falx cerebelli, and the tentorium cerebelli. Does that ring a bell at all? I don't even care if you remember the names per se. What I want you to think of is they help to provide anchoring for the brain because it's so loosey-goosey. They provide a little bit of support and anchoring for the brain. Okay, and once again, I hate to steal stories from him, but these are two stories that I think are applicable. If you ever see a transport vehicle that's transporting, gasoline or oil, okay, inside those big tankers, there are actual panels that they put in. And so if that tanker hits its brakes and it didn't have those panels in, what would happen? All the fluid would go flying towards the front of the truck and probably tip the truck over, right? So there are these panels that are put in that help to do what? Keep the fluid back, right? And these little subdivisions of dura mater help to hold the brain back. So that way, if I turn my head really fast, right, my whole brain won't slosh around in my skull. It helps to separate it and segmentalize it and keep it in place, okay? So once again, I don't really care if you memorize the names. I want you to understand those concepts, okay? So falx cerebri and meninges of the brain. So the three layers of the meninges, dura, arachnoid, and pia, okay? They help to stabilize the brain, but underneath the arachnoid mater is where we have cerebral spinal fluid, okay? Underneath the arachnoid, so between the arachnoid and the pia, so between these guys is where we're gonna have cerebral spinal fluid, okay? So if we have a subarachnoid bleed, what's going to happen? Basically, almost have like meningitis, right? Because you're going to get that bleed into that cerebral spinal fluid. So is that going to be more dangerous than a subdural? Well, I guess it depends on the extent, but theoretically, yes. Okay. So, and we'll get into that in a little bit. Okay. So any questions about, we have the general structure of the brain, we have the general structure of the vertebral column, right? General structure of the meninges. Any questions on any of this? Good? Question? Good? Okay. Okay. So let me zoom back out. Meninges. Okay. So brain and spinal cord. The reason I put this picture on is to show you, to remember that the meninges go all the way down. I think sometimes people, right? Do we know that? Okay, the meninges go all the way down the cord, right? Okay, they go all the way down the cord, so we don't think of it as just being in the brain. Because what can happen with people with meningitis, they can get pain down their back, right? Because they can get that infection down the cord. Okay, so that's the only reason I put that brain and spinal cord, describing that the meninges go all the way down the spine. This is a ton of information. Are we good? Do we have any questions about it? Okay. Okay, good. So ventricles. So we've talked about the brain, we've talked about the outer structures. Now we're going to talk about the inner structures. We've got the different ventricles, okay? If we come in, so we're doing ventricles with cerebral spinal fluid. Let's zoom in. Why am I not? There we go. Okay. Let's zoom in. So we've got the ventricles of the brain. And the main thing that the ventricles do is help to create cerebral spinal fluid. We've got 2 lateral ventricles. Okay, 2 lateral ventricles. And if you look at the picture, you can see, so they would be deep in here. Okay, and there's different parts. I just want you to remember the lateral ventricles for our purposes for now. Okay, there's a 3rd ventricle. And why do we jump right to 3rd? Because we have what? 2 lateral ventricles, right? Okay, we don't name them 1 and 2, left and right, and then we go down to 3rd ventricle. Okay, and then the 3rd ventricle is going to connect down to the 4th ventricle. Okay. Now inside, and they're all interconnected. Okay. There's a cerebral aqueduct that'll connect the 3rd and the 4th. There's connections between the lateral and the 3rd, which you don't need to know. Okay, I want you to know primarily that there are the 3 major groupings, and they're connected by tubes. Okay. Now, inside of these ventricles, we have what are called the choroid plexus, and the choroid plexus is going to be a little network of capillaries. Okay, so we've got the arterial supply to the brain. We'll have off that arterial supply little capillaries that are sent into the ventricles. And through those capillary walls, we'll secrete a little bit of fluid, not a little bit, enough fluid to make the cerebral spinal fluid. Okay, and the cerebral spinal fluid will stay in those ventricles and start to move down into the lower ventricles, right? Are you with me with that? Yes, you guys are getting tired and hot, aren't you? Everybody's energy just went, whew. Okay, so the cerebral spinal fluid will head down from those ventricles and actually sneak out at this 4th ventricle and go down and around the cord and go up and around the brain, okay, in that subarachnoid space. Are you with me? Yes? Okay. So ventricles, so choroid plexus. Okay. Sella turcica, I think that one of the other important structures that we should look at, can you hit the lights for me? Okay, I'll bring my people at home in. So we're looking at the slide that says sella turcica holding the pituitary. Okay, this is a mid-sagittal view. So 2 things. First of all, we can see 1 cerebral hemisphere. Okay, see that white structure in the center? That white structure in the center is what's called the corpus callosum. That callosum allows our right side, C-O-R-P-U-S, C-A-L-L-O, S-U-M, callosum, yep. Okay, corpus callosum. The corpus callosum, guys, is a grouping of white matter. So what is that going to do? Send information. And guess what it does? It allows the right side of our brain to talk to the left side and the left to talk to the right. Because some of our mental functions are unilateral. They're only one-sided. But we've got to let the other side know what's going on. The corpus callosum is a structure that they'll cut if people have persistent seizures, but then they have inability to recognize halves of the body. Okay, so there's all sorts of funky neurological residuals with that, but if somebody's having persistent seizures, so, okay. And I want you guys to see the sella turcica. You can see it's a little bit lower down. In the sella turcica sits the pituitary. Okay, the pituitary is going to be a major regulator for hormones. Okay, major regulator for hormones. We tend to get pituitary tumors. So then people with pituitary tumors can have all sorts of funky kind of hormonal effects on their body, okay, depending on what cells it tends to affect. It likes to affect those tumors' growth hormone, okay? And that growth hormone can actually cause an excessive growth of that patient, for example. But the other thing I want you to note is if you look at the front, right in front of that sella turcica, what cavity are we in? Nasal. So guess where they like to operate on the pituitary? They go right up the nasal. Isn't that amazing? And the other thing that I heard on my little mentor is, and I'm sure this is very old school, but he saw somebody who took a long nail on somebody who had acute, sinus infection and jam it up there. I don't think that's a good thing to do, but it helps you to remember where those sinuses are, right? Okay. But that's, I think, a great picture to see that they can go up and operate on that pituitary through the nasal cavity, which is pretty ingenious, right? The other thing that I want you to see from this picture, because I started talking and reviewing about meningitis to teach you guys, and I really started thinking about the transmission of meningitis, right? Well, one of the theories about the transmission of meningitis is through the nasal cavity. And if you look at the picture that we have here, in the superior aspect of the nasal cavity, we have the olfactory nerves. And those olfactory nerves pass right through holes that go right to the brain. So one of the theories is the infection goes through the nasal cavity and into the brain. Isn't that kind of interesting? So I thought that was a great picture for multiple reasons. Okay, and this is actually a cadaver. Okay. Now, one more thing. Just above the sella turcica, you could see the hypothalamus. Now, the hypothalamus and the pituitary work together for all those hormonal releases. Okay? Hypothalamus is kind of like the boss, telling the pituitary what to release. And you can see they're right next to each other. They're actually connected by a stalk. Okay? Any questions on that one? Good. Okay, so review continued, and I once again have pictures for this. So the spinal column, we're going to go through the different curves of the spinal column. Do I have that there? I do. Okay. I just want to get this in my head so I don't get off. Atlas and axis, intervertebral disc, Schmarl's node, and treatment for herniations. Okay. So kyphosis. If we're looking at this picture and we look at the left side of the screen at a normal spine, so we're looking at the kyphotic spine slide. Okay. The normal curves in the body are known as lordotic or kyphotic. Are you with me? So the curve in the neck and the curve in the low back that moves towards the front is called a lordotic curve. Okay? The curve in the mid-back and the curve in the low back are called kyphotic, the ones that move towards the back. You with me? Okay. People also kind of use them interchangeably with disease processes. So if somebody says that somebody has a kyphosis, it means that they have that dowager's hump, I believe they call it, right? Is that the right term? Dowager's hump. Dowager's hump. Dowager's hump is the little old lady who is becoming osteoporotic, whose vertebrae are starting to collapse. And if you want to know the mechanism behind that, I'd be happy to talk to you about it. And she starts to get that hunchback presentation. I think it's Dowager's hump. I have to look that up. Okay. People reference that by calling it kyphotic or kyphosis. So even though kyphosis is a normal anatomical structure, not structure, but presentation of a curve, people use it kind of interchangeably. Okay. If somebody says that somebody's lordotic, I was totally lordotic when I was pregnant. When you get that excessive abdominal weight, it pulls your low back into that excessive curve, right? So people will also use that term as a disease process as well. We see that with people who are, morbidly obese, women who are pregnant get that excessive lordosis in their low back. Gymnasts, right? I think they kind of train, don't they, to sort of get that excessive curve in the low back, which can really lead to problems. So kyphotic and lordotic are normal terms, but they can be used as disease processes as well. Now, what are we looking at here? Can you hit the lights for me? What's the view, first of all? It's a little bit of a funny view. It's not really definitive. It's going to be, okay, it's going to be a frontal plane, right? It's going to be A to P or P to A. Are you with me? The way that we term x-rays is either a lateral, for the most part, if we're just doing generalized x-rays. A lateral view is when that person is turned sideways and you're looking in from the side, or an A to P or a P to A. It depends on how the x-rays pass through the patient. Do you care about why? Or do you want me to explain it? Not really, yes. It depends on what structure you want to see. Okay, I have a few yeses, I have a few nos, so the yeses always win. So if you could hit the lights for me for just a second. If I want to see somebody's spine and you're taking an x-ray, the x-ray machine is going to be in front of the patient, okay, usually what, 10 feet away, give or take? And behind them is what's called the bucky. And what does the bucky have in it? The film, okay? So whatever you want to look at, you want to put closer to the film. So if I have somebody who's been in a major car accident and want to see the spine, I'm going to put their back against the bucky, and that x-ray will now be called an A to P. So whoever's looking at it knows that that patient had their buck. I sound like the guy from So You Think You Can Dance. That's buck, yo. Okay, they're going to have their back against the bucky. If somebody might have lung cancer, I'm going to put their chest against the film. So their lungs are closer to the film, so we get a clearer image of the lungs. That would be termed a P to A film. I don't know. And then how do you tell sidedness on a film?
Don't they usually stick those little letters?
Yeah, they stick the little letters on. They stick the L or the R on. Okay, so you should know. But if you don't know, what would you look for? I would look for the heart, right? Okay, the heart's going to be primarily left-sided, of course. I saw that, actually, transposition of the organs. I went with, you guys probably know her, what, Julie Wells Chachos? Okay. She and I went to the Bodies exhibit in Rochester, and we were looking at an infant, unfortunately, but we're both standing there. We're both going, tuk, 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 tuk. She's like, I go, oh my God, it was total transposition of their organs. Everything, really.
But he was also born with a cardiac issue, but he has extra cardia and then everything.
It's fascinating. Is he okay with one of the students' sons has transposition of their organs?
While on bypass, so
Yeah.
that's actually what is his now. But he's
Okay.
graduating tomorrow.
Oh, so he's 18, 17, 18? Awesome. Good. How did we get off on that? Oh, the views. Okay, so the views. So, and usually, guys, just one other quick thing about, spinal x-rays is they usually won't do thoracolumbar. They'll do thoracic, they'll do cervical, they'll do lumbar, because then they're getting the appropriate thickness. You're going to change the intensity of the x-ray to be appropriate for that width of that area. So they tend to focus in. So this is an unusual film. But the reason they did this, it's kind of a thoracolumbar combination, is to show the scoliosis. Okay, so scoliosis, this is going to be, I don't know if it's P to A or A to P, but they're showing the thoracolumbar spine and they're showing that curvature. Okay, so it's going to be a lateral deviation off the midline. Okay, normally the spine should be straight. Now, what happens with scoliosis, for the most part, is it's compensatory. Are you with me? So they're not going to get a C-shaped curve just going one way. We like to keep, it's called writing reflex, we like to keep our dens, C2, above our sacrums, S1, S2, but whatever. We like to keep our head above our sacrum. So if we keep going off to that way, well, we don't like that too much. I mean, we can't accommodate to it over time, but we're going to want to bring it back up. So you get that S-shape presentation. Okay, and I believe that the curve usually will go away from the heart. There's another condition, and I'd really have to dig deep for it, where the curve, so if it's moving away from the heart, we'll have it going to the right in the thoracic spine and to the left in the lumbar. There's a condition, it comes with that, oh, it's going to bother me now, that goes to the left and can actually start pushing on the heart. Okay. So just a quick little snippet of information. As the patient progresses, if they get up to 40 degrees, it's going to be a neurological surgical console. Because at 40 degrees is when they start to get compromised onto the lungs. Okay? That's usually rule of thumb. All right? So scoliosis. This is a great, horrible picture, but good clinically to learn. So if you could hit the lights for me, I'm going to bring everybody at home in closer. Okay, and once again, we know it because somebody was kind enough to put the arrows on there for us. Anybody have any idea where we are, first of all? Yeah, okay, so let's say it clinically. This is going to be in the cervical spine. Okay, so this is going to be a cervical spine x-ray. We're looking at the top, right? What's this going to be here? I'm pointing, so we're looking at where are we and what has happened. We're looking at the cervical spine. There are green arrows on the left. There are right arrows on the right. And if you look at that right arrow, that is actually going to be C2. Okay, C2, and if you look at that front view, okay, C2 has a projection that actually comes up and it articulates with C1. This is going to be a prime area for trauma, for head trauma. So a couple of things can happen, and what these arrows are pointing out is that little nub that's sticking up. Let me see if I have, wow, I didn't put in, okay. I didn't put in just a regular picture of C1, C2. So C2 has a little nub that sticks up. Okay, C1 is called atlas. It's a nice round ring. C2 has a little nub called the dens that sits right up into that ring. Okay.
Do you need to pull back so that they at home can see your hands?
Okay. Oh, maybe. Do you guys need to see my hands at home? If you could you hit the lights again? So, well, let me just draw while I'm here. We'll just draw a quick picture. And then I could tell you guys are getting fried. We'll stop after this. Oh, wait. There we go. Okay. So we're talking about C1, C2, and I think that this is clinically relevant because a lot of times with head trauma, we can have fractures of either C1 or C2. Okay. So C1 is a ring, basically. Okay. And it sits at the base of the skull and it holds the skull up, and that's why it's called Atlas, right? Because Atlas in mythology held up the world. Okay, so C1. Now C2, so you imagine that ring. C2 has a little, it's called the dens, okay, and it sticks right up into C1, okay. So what can happen with head trauma is one of two things. You know, if you can imagine with really hard whiplash, right, you take that and you fling it, very nasty stuff, and this little nub can just get ripped right off. And that's what's on that x-ray, and I'll take it back in and show it to you in just a second, okay. If you have somebody who decides that jumping into a shallow pool is a good idea and they land on the top of their head, well, C1 likes to go like this, right? Because you're taking the head and you're jamming it down onto that nice skinny little round bone that doesn't even have a vertebral body, okay? So two fractures can happen, okay? So C1 and C2, the first two. Now, the reason that that's important to know is because we've got what right there? We've got a little bit of the brainstem just dipping down, and then we have the top of the cord. Very, very bad, okay? So if you damage the top of the cord, all of the signals going from the brain and down can get disrupted. Are you with me? So every time somebody has had a neck trauma, you should do what? They should go right for an x-ray, okay? So here we go. So where we are and what has happened, we're looking at really, yeah, this looks weird. The one on the left looks like an x-ray. The one on the right, that rim looks weird. But anyway, I think this is an x-ray. Yeah. Can't believe that'd be a CAT scan. Anyway, so you can see on the left where the green arrows are, you can see that that dens, that projection has been ripped right off. Okay. And then you could see on the right side where it's ripped and it's also moved a little bit, fractured, I should say. Okay. You can also, with people who have RA, get instability at this juncture, okay? So then, if they have a head trauma, they're even more prone to neurological complications, right? Okay. All right, we're going to wind up about 10 minutes early today because you guys are looking a little fried, and it's getting hot, is it not? So we'll finish this. We'll finish herniated discs and Schmerl's notes next time, okay? Any questions? All right.